Hi,
Hi, Dr. Peterman. How are you?
good. Just uh, getting the lighting a little different. What's the format of this? I've never done one of these before.
Well, I will start things off. Director Jepson will provide a few opening remarks, and then Dr. Hahn and Elke Shaw-Tulloch will also provide some opening remarks, and then we'll take questions from the media.
Oh, so I that's what I thought. I don't need to make any presentation or anything. I'm just here to answer questions if they have any for me specifically. Is that correct?
Yes, and when I start things off, I'll introduce all of you and just let them know that you're here as a special guest to answer questions when we open it up to questions from the media.
Okay.
Does that sound
Um,
okay?
okay. Well, it'll be embarrassing if no one asks me questions.
I suspect you'll probably get some questions.
Did yeah, did did you see that? K, KTVB did a really nice. I don't know if you saw it
Was it
with
just
me
yesterday?
yesterday. Yeah, on West Ada. Again, separate from the fact it was me. I mean, he really covered it step by step, systematically. I, of course, a lot of people will listen to it, but I thought it was really good.
Yeah, I have not had a chance. I scanned.
Yeah,
Yeah,
there's a little. I get glare in my glasses, but unless I go like this, it's just
yeah.
hard.
I think it will be fine. So and just so you're aware, we do record these and we do post them on our coronavirus.idaho.gov website.
Okay,
So that'll be available. Usually it's available around 4. Um,
okay.
Sometimes a little earlier, sometimes a little later, but
Um,
we get it up there eventually.
well, at this point, there are no secrets about me.
Right. Yes, yes, that is true. Well, thanks for joining us today. I think
Okay,
this will be good. We're really trying hard to get the message out there that the hospitals that, the capacity is an issue. And you'll hear, I think Director Jepson's going to cover a lot of that in his opening
okay,
remarks and things like that. So, is there
okay.
something, would you like to say something maybe after Elke?
I can, again, the media, many of them I know. Some of them actually are on listening now.
Yeah, they're
Um,
joining as we
I'd
speak.
rather, I'd rather not give a talk. I'd much
That's fine.
rather answer questions and, you know, I can tell you yesterday we hit two records again. Previous record was last week. We saw 1,500 in the urgent care. Monday we saw over 1,600.
Oh my gosh.
And the most tests we've ever done ever, even going back to December and January. So,
Wow.
I'm worried. Nikki, should I mute and then I'll just wait for someone to call me?
Yes, yes, I
Okay.
think that would be good. I think the way that we normally do this is Elke Shatulik will kind of be the traffic cop. I'll call on
Okay.
reporters as they raise their hands and that kind of thing, and then they'll ask their
Okay.
questions, and then Elke will kind of help manage who answers those questions. So,
Okay. I'm going to go ahead and mute.
okay, sounds good. Thank you, sir. Okay, we'll do a quick sound check and we'll give it another couple of minutes as people are joining. Like we're getting a good crew today. Everybody can hear me just fine?
Nikki, I can hear you.
Perfect. All right. Thanks, Director. And I can hear you as well. All right, it's 2:30 on the dot. Thank you for joining us for this media briefing about COVID-19 in Idaho. My name is Nikki Forbing-Orr, and I'm going to be the moderator today. Please note that everyone should be muted unless they are speaking. American Sign Language interpretation is available today. If you search for interpreter Stubbs and hover over the three little dots in his window, you can lock it in place so it's always visible. To start us off today, Health and Welfare Director Dave Jepson will provide some opening remarks, followed by Dr. Christine Hahn and Elke Shaw-Tulloch. I'm also very pleased to announce that Dr. David Peterman from Primary Health Group has joined us today and will be available when we open it up to questions from the media. And with that, I will turn it over to Director Jepson.
Well, thank you, Nikki, and welcome to everybody to our now weekly COVID briefings from the department. And particularly welcome to Dr. Peterman. He graciously accepted our invitation to join us today, and it will help us out on questions when we get to that part. So let me start with some good news, actually, which is the number of vaccinations continues to increase each week. And with those 65 and older, we're actually getting very close to 80% with the first dose. With 12 and older, we're at about 53% with the first dose. Over 200 million Americans and over 800,000 Idahoans have taken the vaccine, and just want to say thanks to all of you out there who have chosen to get vaccinated. However, this Delta variant continues to move us the wrong direction. Our statewide low for cases per 100,000 was just about 6 weeks ago on July 5th at 3.3, and today we're at over 30. So we've increased tenfold in our case rate across the state. Our percent positivity is coming from a low of 2.8 just a few short weeks ago to 12.8% statewide. And our percentage of long-term care facilities was down to about 14 just again a few short weeks ago with either a positive staff member or patient. And we're now over 60 of those long-term care facilities with COVID case with either staff or with a patient. Probably most concerning is the number of COVID patients in the hospital. We are actually near, just below our previous peak in December for number of patients in the hospital with COVID. And very concerning is that the number of patients in the ICU with COVID-19 is now the highest it's ever been across the state at any point during the pandemic. And the vast majority of our hospitalizations are from unvaccinated individuals. I had the chance to go visit one of the local ICUs here in the Treasure Valley over the weekend, and it's really hard to describe the amount of sadness and suffering that's occurring there. The ICU unit was full of COVID-19 patients that were all struggling, many for their lives, and it was very, very challenging for them and their families. and also on the medical staff that work there, who are working every day to keep them alive. In general, our hospitals are very full and very stressed and very near their capacity. In fact, if you would like to volunteer to help out at a hospital, we'd welcome the public to do so. Help is really needed from housekeeping to medical staff. And if someone is interested in volunteering to help out a hospital in their local area, they can go to volunteeridaho.com. Again, that's volunteeridaho.com in order to sign up to help out in some way. With all of the stress the hospitals are feeling, and the numbers continue to go the wrong way for them in terms of patients, and particularly patients in the ICU, there continues to be a great amount of efforts to avoid having to go into crisis standards of care. The hospitals work daily and hourly to find additional resources and ways to service the patients coming to them. The state is involved, the department is involved in coordinating across the state resources, as well as open beds, et cetera, to help everyone stay out of crisis standards of care. We are dangerously close to crisis standards of care. In fact, last week, we brought together the Crisis Standards of Care Activation Advisory Committee just to prepare them in case we actually were called upon to make that decision. And we will keep a close eye on this. We're going to continue to do everything we can to avoid crisis standards of care. But we are ready should a hospital or multiple hospitals request that we move to crisis standards of care. But we have the answer, and the answer is the vaccine. And for those of you that have chosen to get vaccinated, I say thank you. And for those of you who have not yet been vaccinated, I urge you to consider getting the vaccine and do it for yourself and for your family. And I can tell you right now, the hospitals are at or over capacity. And with that, I will hand it over to Dr. Hahn.
Thank you. Thank you so much, Director. And yes, we're just want to echo the sentiments that we are very concerned about where we are at right now. We were very hopeful last spring with our declining numbers, the availability of the vaccine, the coming of the summer months in which we thought we might see a seasonal dip, and we thought we would be in a better place now. I just wanted to say a few words, just updates about the vaccines. I know you all are very aware of the news, but just to make sure, clarify a few things that might be a little bit confusing to the public. So you're all aware that the FDA did fully license the Pfizer vaccine for 16 and above. And what's a little bit confusing about that is that, of course, the vaccine can be used in 12 to 15-year-olds, but in that age group, it is still considered under emergency use authorization. So just a little bit of just something to be aware of just using our language carefully about the vaccine, that there still is a emergency authorization use of this vaccine. In addition, of course, the CDC's advisory committee, after authorization by the FDA, also recommended this third dose of the Pfizer vaccine or Moderna vaccine for moderately or severely immunocompromised people. And that third dose, which is to be given 28 days after the first two, or longer, if it's longer, that those are not considered booster doses. They're actually considered a 3-dose series in those people. So that's an augmented series or a third dose. And I'm careful about that language because, as we know, the White House announced recently that there is a plan to make recommendations for booster doses of the vaccine for people who finished the 2-dose series, and that in that population, the term booster will be used because, so speaking for myself, and I'm sure some of you who've received the series, the concept is that we probably got very good immunity from those 2 doses, but that immunity might be waning or in danger of waning. And so the booster is designed to boost it back up to where we want it to be. So those conversations, that was a little bit confusing, the announcement from the White House, because the FDA, again, has not authorized booster doses in most healthy people. And yet we, and I'm sure some of you have heard, a lot of the public is confused about that, is looking for their booster dose. I heard I can get a third dose. They might be getting it confused with the recommendation for the immunocompromised. So I want you to be aware that the CDC, the FDA is working to authorize that booster dose The CDC is meeting next Monday, August 30th. They will be meeting to discuss a few things, mostly to talk about Pfizer now as a licensed vaccine, to refresh on the safety and efficacy data for Pfizer and to reaffirm its recommendations. But also there'll be some discussion of the booster dose. But my understanding is there will not be a vote at the next Monday. That might not occur until September. So very difficult messaging, because of course we're happy to see things moving forward. We're happy to see the availability of vaccines increase and recommendations being made, but it's a bit of a confusing time with all the recommendations being made. So I think I'll leave it at that, and certainly am available for questions later about the vaccines if needed. I think we also have folks from our vaccination program on in case there are questions about the rollout in Idaho.
Okay. And I think
Oh, go ahead. Go ahead, Nikki. Thank you.
that's okay. Thank you. I think Elke Sheltelik has a few remarks to give as well.
I do. Thank you, Nikki.
Great.
Let me pull this up here. So thank you, everyone. Appreciate you all being here again this week. As a reminder, last week I touched on the funding that the department's making available, or will be making available, for K through 12 schools, private, public, and private, for COVID testing. And as a reminder, it was $30 million that we're making available through state public health for both public and private K through 12 schools to support their COVID response and testing needs. So this is a completely voluntary opportunity for schools that gives them maximum flexibility and allows them to determine the appropriate COVID testing program that works for them. Our division has received approval since our last press briefing. We've since received approval from our funders, which is the Centers for Disease Control and Prevention, or CDC, for a redirection of our existing appropriated federal funds. We're a couple of weeks probably out before we can start the flow of funds out to schools, since we just learned of this ability to do this redirection. But we're in the process of developing a registration form for schools to submit the request to participate. And we'll also be working with our partners in the Back to School Task Force to help get the word out, and the registration link and supporting information will be posted on the State Department of Education website with the recent Back to School guidance documents that they just published last week or so. So as soon as it's available, we'll make sure that it's posted, and we'll make sure that we're getting that word out in the streets. It's also anticipated that schools who choose to avail themselves of the funding can use it in ways that meet their individual school needs. So this might look like carrying out a comprehensive screening and diagnostic program, if that's the right fit for them. It could be hiring a testing coordinator that they have on site or is consulting with them, or just personnel that supports their overall testing and follow-up. They could use it to purchase test kits and or hiring a service to do the testing on the school's behalf. The choice of how they want to implement these funds are entirely theirs and per their own individual policies. The department will be providing technical assistance regarding those testing options, associated requirements for specific types of testing, so we're guiding them through what those testing options look like, and also reporting any of the testing results and helping them so they can be responsive to any positive result that may come in. So we look forward to making these funds available as soon as we can get everything pulled together, but wanted to give you this most recent update, and we'll of course be bringing you any new updates as we move forward through the weeks of our press briefing. And Nikki, back to you.
All right, thanks, Elke. So we will now take questions from the media participants. Please raise your hand in WebEx or type your question into the chat area, and I'll read it aloud for you. When I say your name, please unmute yourself and announce your name and media outlet before asking your question, and then also please remember to clear your hand when you're done. Looks like we have our first hand up from Audrey Dutton.
Good afternoon. With the increase in cases, how behind are contact tracers and case investigators? How far behind are the public health districts on keeping up with those?
Thanks, Audrey. I'm going to actually turn that over to Dr. Turner, who is on the phone or on video.
Yeah, thanks, Elke. Audrey, so it's going to vary by public health district, but what happens when they feel like they're starting to drown in positive lab results is that the investigators start prioritizing and shortening the investigation so they don't get as comprehensive an investigation done, but they kind of ask those very, very important basic questions such as symptom onset. That what I would say is that some have more capacity than others, so they're all incredibly busy and are working really hard to stay up, and some of them are, you know, probably a little bit more stressed out than others. You know, I don't want to speak on behalf of the public health districts, but I do know that we're seeing these case counts all across the state.
Nikki, you're on mute.
Thank you. Our next, sorry, missed the mute button there. Our next question is going to come from Hayat Noormina.
Hi, thank you. Realizing this is early, but now that the FDA has granted full approval to the Pfizer vaccine, have you seen more demand for vaccine appointments? Is it making a difference so far?
Yeah, I would say anecdotally, yes. We're curious to see how things unfold over the next little bit, but I'm happy to turn it over to Sarah Leeds, who's also on the call, since she's seeing things more real time.
Thanks, Elke. Yeah, so we've just have a nice little job.
And okay, maybe Dr. Peterman could comment on that.
Just about to get asked for that next. Yes, thanks. Dr. Peterman, do you mind sharing your experience?
Yeah, thank you. First, let me begin by thank you for inviting me to participate in this call. If we could just pause a second, and I even wrote my list down so I don't leave anyone out. But I've been working with some of these people so many years. I can tell you they're always available because I've either called them, texted them, emailed them Saturdays, Sundays, at nights. In fact, I get a little panicky if I haven't heard from some of them in 48 hours. This state would be in significantly more trouble. There would be more deaths without health and welfare and everyone on this call. So I just wanted to stop and thank them. They do have done an incredible job. So in terms of vaccinations, I'll say we're seeing a slight increase. It's very slight. Frankly, we are so overwhelmed with testing and actual visits to our urgent care. The demand for shots may be somewhat slowed just by we're so overwhelmed with taking care of either patients that have symptoms or patients that are seeking tests. Last week, we set all-time highs in our urgent care for ill people, which was over 1,500. The previous record for that's the whole history of the country, was 2 weeks ago, which was 1,300. And Monday we did over 1,600. Also yesterday, the number of tests we did, PCR tests, was again set a record. It was more than we had done in a single day in November or December.
All right, thank you, Dr. Peterman, and thank you for the kind words. I'll thank you on behalf of everyone on the WebEx here. All right, our next question is going to come from Heather Ann Wagner.
Thank you, Heather Ann Wagner, KPVI. For individuals who received Johnson & Johnson, if boosters are recommended, would they be able to switch which vaccine they received? And if so, would they need a series of 2 to 3 shots?
I think I'll hand this off to Dr. Hahn, and then we'll follow up with Dr. Peterman's experience.
Sure. There is no recommendation right now for Johnson & Johnson recipients to get a booster. That leaves people who, the natural next question is, what are they to do? It does leave them a bit in the lurch for right now, or in a bit of uncertainty. CDC is trying to get the right data to make a recommendation, but right now that there's not enough data to make a recommendation for that population.
Well, I'll defer to Dr. Hahn in terms of the most up-to-date recommendations. I would make a couple of comments about Johnson & Johnson. The information that came from the CDC came in such a manner that it really frightened people. And essentially, we have no demand for that vaccine. But the tag along with that is the confusion now about an augmented dose. I'm carefully not using booster for Johnson & Johnson. And I would just add to this, it's been challenging, some of the communications from the CDC. For someone like myself who's practiced so long, the CDC, in a sense, is our director. It's our Bible. It's who we followed for all and everything that's infectious diseases and certainly public health. And there has been confused messages from the CDC, and it's been challenging for the public, but it has made it at the level of a clinic somewhat difficult, because you're now getting flooded with phone calls. Anytime, I may be the only one in the United States who doesn't love Dr. Fauci. And the reason is he makes a statement, a general statement, and people who listen to him then have questions, and they flood our phones, hundreds of calls. It's sort of a lack of understanding that the level of primary care, communication is everything. Frankly, our state health department right here in Idaho is very careful with their communication, so we appreciate that.
Thank you.
All right, our next question is going to come from Kyle Fonensteel.
Hi, I've got a two-part question that I think for Dr. that part. So will coronavirus patients who test positive know if they have a variant strain of the virus? Will they know what strain of virus they have? And how does the state know that 90% of cases in Idaho are caused by the Delta variant?
Thanks, Kyle. That's a great question, and we were actually just talking about that in a call this morning, and Dr. Ball did a great job of relaying that information this morning, so I'm going to turn it over to him.
Thanks, Elke, and thank you, Kyle. It's a interesting question to answer. The short answer is, if a person goes to get a COVID test, the PCR test was not going to identify what variant of COVID they have if they test positive. That being said, we are doing a wide variety of sequencing, and our capacity to do sequencing has really increased. So if you look at the 4-week period between the middle of July to the middle of August, we've sequenced almost 800 positive samples. And of those, 96% of them have been Delta. And so I think the most likely answer to that question is if you get tested and you're positive for COVID-19, you most likely have the Delta variant, because that of all the samples that we're sequencing, and we're getting a sort of a random selection of positive samples that we think would be good candidates for sequencing, and almost all of those are the Delta variant, and that's statewide, regardless of location in the state. That's what we're seeing. So I'm not sure if that answers your question, Kyle.
Yes, thank you. So people should just kind of safely infer at this point that if they have COVID, they probably have the Delta variant.
It's much more likely that they have the Delta variant than any other variant or any other lineage, just based on what we're seeing in the state and also what we're seeing nationally. What we're seeing in the state is very reflective of what the CDC is showing in their national surveillance. 98% of these strains are the Delta strain. It's about the only strain that's in circulation in the United States right now.
Okay, thank you. Our next question is going to come from Shiro Matsuzawa.
Thanks, Nikki. Shira with KTVB. With kids going back to school, does the state plan to track those COVID cases in schools again, and will schools be required to report that data to the state?
Yeah, thank you. So, of course, all positive cases are reported to the state. We are doing the same. We're continuing to monitor what's going on in the state. Some schools, as you know, report on their website the number of cases that they have. But the funding that we're making available, we will have some reporting requirements for those schools that choose to participate. And I'm happy to turn over to Dr. Turner for a little bit more depth on what all they'll be required to provide to us.
Thanks, Elke. So first of all, yeah, I just want to reiterate that when a lab performs testing and they get a result and they're testing for SARS-CoV, the virus that causes SARS-CoV-2, the virus that causes COVID-19, they are required to report that result with personally identifiable information to public health, and that's what initiates the public health investigation, of course. For schools who are planning on doing testing programs in their school, depending on what sort of testing program they decide to implement, it will depend. So if they are hiring a contracting lab or they hire a contractor to do that program for them, whoever is generating that test result is required to report. So it might be their contracting lab. If the school is testing in-house and doing the testing there on site, they will be required to report. So it's whoever's sort of generating that test result. I think that's probably the best way to think of it. But for schools who do receive funding from the state for implementing some kind of testing program that they think works for them, there'll be very minimal reporting requirements. We do not want to get in the way of the program. So we'll definitely want to know how many tests they conducted, and we'll want to know, what their costs were. But the actual reporting of results is up to the person generating the test. I hope that's clear.
Okay, we'll move on to the next question. That's going to come from Zach Kellogg.
Hi, Zach Kellogg, KLEW News in Lewiston. So the question I had is that last week you guys talked about how as hospitals were increasing in terms of the numbers of COVID-19 patients,
Staffing is the predominant factor that's stressing hospitals out in terms of their capacity to care for patients. And so we are employing lots of different communication channels and problem-solving channels with hospitals to try to solve for the staffing issues. We've submitted federal requests, as I mentioned last time, to help support that. And we're also looking for additional funding to help support recruitment and retention of new staff for the hospitals. But I'll turn it back to the director to get more to the kind of the heightened level that we're at right now.
Thank you, Zach. Excellent question, and thank you, Elke. I think we're pretty close to there in terms of capacity in hospitals, really around the state. The biggest limiting factor has been staff, but we're also seeing hospitals getting creative in terms of where they're placing ER patients and ICU patients. I mentioned at the beginning of this call, I toured an ICU or visited an ICU over the weekend, and there the ICU is full, and they converted a cardiac recovery unit into additional ICU space. That ICU space was full. And we have a daily call that's facilitated across the state to identify where people have needs, where hospitals have needs, and where there might be resources. And it's getting harder and harder to find solutions as hospitals say, hey, I have an ICU patient and I don't have room for him. Hey, I'm a critical access hospital in a rural community. I've got a patient that needs a higher level of care. Who can take them? And I would say right now those are tough conversations, and it's not always obvious or easy to find an answer of where to transfer a patient into a bed. And in fact, we've had one today in our call today where a patient needed to come out of a rural setting, and we were unable to find an ICU bed this morning. We hope one opens up this afternoon, but that's kind of where we are at the state level. The hospitals continue to work on this problem very closely. They've expanded space they're using for ICU, for ER, for med-surg. They continue to be creative on the staffing side. We've been helping with the request to our federal partners and across the state. But if the question is how close are we to hospital capacity, I would say we are over hospital capacity right now.
Thank you.
Okay, our next question is going to come from Rebecca Boone.
Hi there, I have a couple. So after this one, I'll re-raise my hand, just FYI. I'm wondering, first of all, if there's any way to track if there's been an increase in morbidity rates for normally non-fatal or serious outcome illnesses that might be treated in the ICU as a result of this capacity problem.
Rebecca, just to clarify, I'm presuming you mean non-COVID morbidity questions.
Yes, thank you.
Elke, I think I could answer that. And certainly others who may. But Becky, here's what I think. What our concern is, which is to go back through what those patients with chronic illnesses just went through a quarantine. While they were in that quarantine, whether you use telemedicine or not, there were many, many, many people with chronic diseases that did not get the care that they would normally get. And so if you're hypertensive, maybe you're depressed, and maybe you're overweight, all three of those things, and diabetes, 4 things, could get worse if you're quarantined and frankly have limited resources, you can't be with family and all the rest. Whether your primary health, look with our family doctors treating people with chronic diseases and those 65. Aren't COVID admissions, there are still higher admissions, or a primary health is seeing individuals with chronic diseases more frequently because they didn't get the kind of treatment that they needed. I think I can comfortably say in my discussions, which are not always daily, but close to it, certainly in Southwest Idaho, and I can speak for the rest of the hospitals, no care is suffering in the hospital. There's no non-COVID illnesses that aren't being treated the way they should be treated. I am completely unaware that we are not at that point. But the other point, which is these chronic diseases that have not had the attention they should have, or in a sense were behind, those are creating more problems. And I would just add one other thing, and certainly, Becky, you've heard me on this. Understand that if primary care all over the state is overwhelmed, there's not an alternative. The emergency rooms, they're rooming patients in the emergency room today and tonight with sick patients until a bed opens up. So this capacity problem, while it's not measured and I think unfortunately not discussed in national media, there is a tremendous concern, particularly on my part, in primary care. If we are setting records in August of 1,600 patients in urgent care daily, at some point we can't see all the patients. That is really, really concerning. And if primary care cannot see the patients and, in a sense, triage them or do what's necessary to keep them out of the hospital, I'm very concerned. And I would also say that the people on this call are aware of that. The director and his whole team are aware of this and are trying to help and support us.
Thank you.
Okay, our next question is going to come from Kevin Richert.
I wanted to follow up on the school testing. I know that it's still kind of a work in progress in terms of getting the money out to schools, but can you give me a better sense of what you're hearing from schools in terms of their needs, the demand for testing? Give me a sense of what you're hearing at this point.
Thanks, Kevin. I would say most of the local, I guess, connections that we hear about schools are through our local public health districts and their natural relationships they have with local school districts and schools. And so we are hearing that, they're reaching out to the health districts, wanting help and support. I think we've got schools around the state that are going to be interested in this funding. We don't have an established mechanism yet, as I mentioned earlier, for them to reach out and do this registration. We hope to get it out soon. So just anecdotally is really the only information I can give you. It seems like we've got schools that are interested, and we hope that making this money as flexible as possible to meet their local needs will increase the participation even more.
And just to follow up really quickly, because I wasn't clear when Shira asked about it before, is the state going to maintain a database of school positive cases as you did last school year?
I'll turn that one back over to Dr. Turner again.
Yeah, thanks, Elke. So, Kevin, it's a great question. And, last year, there is no formal mechanism. So I'll just walk you through the life of a lab report. So when we get a positive lab report for somebody who is under 18, there's nowhere on that lab report that tells us that this person went to school X, Y, and Z. So that is all gathered as part of the investigation. And what we're seeing right now is increasingly less cooperation with our disease investigators who are doing these investigations and trying to provide public health recommendations and then help with notifying contacts who may have been exposed to a positive case. So we do our best by working with the public health districts, trying to work with the schools, lurking on their websites to see what they're publishing to pull together some sort of statewide picture. And we're looking at whether or not there's a better way to do that this year because it's super time intensive, manual, and not necessarily comparable from school to school. I will tell you that if any school that does receive these funds and reports back to us, like the total number of tests they did, the total number of positives they got, we will make those data public in aggregate. But as far as every school everywhere in Idaho, it's really difficult to do a standardized statewide report. So But we're working on a better method so that it's more easily understood by the public, by the parents, and that the schools are happy with it too.
Okay, our next question is going to come from Audrey Dutton.
Thanks. I wanted to ask about early treatments and prophylaxis. Obviously, we've been hearing a lot about some of the unapproved or unrecommended treatments, but we also have the monoclonal antibodies. How much are providers in Idaho using these medications for early treatment or prophylaxis? And what are kind of the plans to make them more available to patients?
Thanks, Audrey. I will start. I'll turn it over to Dr. Hahn, and then I'll ask Dr. Peterman to give an example of what he's maybe doing in his clinic. So at the highest level in the state, we are certainly encouraging the use of monoclonal antibody treatment, and I can ask Dr. Hahn if she wants to maybe get into a little bit more about what that is exactly. I think that would be helpful. But we're supporting hospitals increasing the use of this treatment methodology. We're also looking at how we might be able to support the initiation of even clinics that are outside of the hospital setting to help just provide support to the communities. And so that said, in a nutshell, we are looking at how we can better support the uptake of monoclonal antibodies across the state, and in particular in the hardest hit areas where we're seeing higher caseloads and where maybe their vaccination rates are lower and hospitalizations are more stressed, or hospitals are more stressed. So those are the things that we're looking into right now. And then let's see if Dr. Hahn would maybe give an overview of what monoclonal antibodies really do.
Yeah, thank you, Elke. So I think most of you have probably heard of them or seen some of the headlines recently. Florida has just announced a big initiative to try to increase use, and I think other states are following suit. We've been working diligently these monoclonal antibody treatments, which for a lot of people, I describe them as kind of similar to the idea of when we used to get gamma globulin shots before you went traveling. You had to have a big shot of antibodies for hepatitis prevention, really. And but those were naturally produced antibodies, and these are all lab produced, if you will, and they're specific to COVID. They've been shown to work in keeping people out of the hospital who have certain risk factors. So people over 55 that have heart disease or lung disease, older people, even if they don't have underlying conditions. So there's a list of criteria, and providers can refer patients for this treatment. The challenges are, and I am, be interested to hear what Dr. Peterman has to say. From our perspective, what we hear from providers around the state is it does take a intravenous infusion, or you can consider a subcutaneous injection, but either way, it's a medical procedure. There has to be an observation of an hour afterwards, et cetera. And hospitals are already strapped with their ERs are already full. And other places don't necessarily want COVID patients coming into their doors. So other places that you might think about that could do the work, there's challenges with having infectious patients come in. So nonetheless, like Elke mentioned, we have reinvigorated our efforts to try to increase use of this as we've seen the surge start, and initiated discussions with several healthcare facilities around the state. And we're hopeful that they are using it. We do get reports on how much monoclonal antibody is being distributed around the state. So we are aware that it's being used throughout the state, but we are trying to increase that. And I will ask Dr. Peterman what his perspective is on this.
Yeah, thank you, Chris. And of course, I'm a pediatrician, so I'm not someone who's using Regeneron. So there are two parts to this. Early on in coronavirus, or midway through on, we created a team, our CRT team, which expanded in size in terms of nurse practitioners, or contracted depending how many positives they were. that team had in front of them the protocol for the use of monoclonal antibodies. So when a patient was positive and fit the criteria, they would inform the patient, who would then go to their primary care doctor and follow up. As we've now this turn time around gotten so busy, we are now have educated all our providers, and so they have the criteria. They get the positives of their patients, and then they refer them, at least in our area, to either St. Luke's or St. L's for Regeneron. And there is a process. Everything Elke and Chris said is correct. There's such a demand for nursing services and everything else at St. Luke's, and then even in our own clinics, we're just trying to keep up. So we're of course not giving as much as we should.
And how does our use of monoclonal antibodies in Idaho compare with other states that have similar levels of outbreak?
That is a great question. I don't know the answer, Dr. Hahn, do you?
Yeah, I was just going to say, Audrey, that is a good question. And especially, as you know, the disease burden in states has varied over time, and as has the monoclonal antibody use. So I don't have the answer to that. We could certainly see if our preparedness program, they get that information initially from the feds, that distribution throughout the country, they may be able to answer that. And we can certainly look into that to see. I know it's a struggle everywhere, as Dr. Peterman alluded to. It's a challenge because everyone is so burdened, and we hear that from around the country. But we can see if we can get a direct comparison.
Got the question captured.
Okay, our next question is going to come from Becky Boone.
Hi, Becky Boone, Associated Press again. Hey, I'm wondering if anybody can talk about what we're seeing in kids with this Delta variant in Idaho specifically, and what we anticipate as school start, and if there's any data statewide to show which school districts or how many school districts are considering interventions like mandatory masking.
Yeah, I'll start with at least what we know of school districts that are doing some sort of mandatory mask policy, and I believe just what we're hearing the same as you, probably, things that we're seeing in news feeds and limited conversations. But to date, I think we're up to 4 school districts that I know of. We have Boise School District, Moscow School District. We know that West Ada is having a meeting today to contemplate it. Lapway, I believe, is the other, and there was a 4th one that I'm drawing a blank on right now. Blaine, thank you.
Yeah.
So we're learning as we go as well. I think Dr. Turner would be a great person to address what we're seeing in terms of cases in kids, as she's tracking all of that information. And Dr. Hahn, if you want to jump in also, please feel free. And then Dr. Peterman, you can tell us what you're experiencing in your clinics with your pediatricians.
Thanks, Elke. I'll start with the dry data piece of it, and then maybe Dr. Peterman can describe what the kiddos look like coming to see him. So to start off with, we sort of look at the age breakouts, kind of very young, 0 to 4 years old, and then sort of your preteens, 5 to 12, or younger children and preteens, 5 to 12, and then we look at teenagers. And I will tell you that what we're seeing in the youngest children, so these are the kiddos that are less than 5, so between 0 and 4 years of age. We just hit, last week we hit a new outbreak record for the number of cases reported among that particular age group. So that was a grim milestone, so there's that. But we're also seeing increases across all age groups. I will tell you that the level of increase is higher in younger kids than it is in, sort of young adults, and older adults. So, and keep in mind that anybody who's between 0 and 12, it cannot be protected with the vaccine. So we are seeing very concerning trends among children. And I'll turn it over to maybe Dr. Peterman to talk about what he's seeing in the clinic.
Thank you, Kathy. Just so you're aware, our data that we generate weekly, I share with Dr. Turner, and it's very helpful because I guess, unfortunately, as our data shows increases, Dr. Turner's data mirrors that. It's a good check for both of us, and our intent is to give Dr. Turner and her whole team as much information as they can to make decisions for the state. So there are a couple of ways to look at this. First of all, the positivity rates for every group in our data has gone up: 0 to 4, 5 to 12, 12 to 18. The 12 to 18 in our data right now is at 20%. 6 weeks ago, that was about 5-6%. The 5 to 12-year-olds is 13 to 14%, and 5 weeks ago that was around 3 or 4%, and that figure's about the same for the 0 to 5-year-olds. What is most concerning is tracking the number of positives primary health had per week. July 7th, if you look at from 5 to 18, we had, I think it was 6 positives for the whole week. We're, in a sense, I accumulated on a weekly basis, so in a sense, I'm a week behind. And last week we had 123. So if you do that math, that you can't get more frightening than that. Because if you multiply 4 or 5 to get 123, you do that math now the next 4 weeks. Now we're really into a scary territory. So I think the media has heard me on this subject, and frankly, I don't think I can say it enough. I'm extremely concerned about the children. Unfortunately, we have seen Texas, Florida, Arkansas, Louisiana. 4 weeks ago in Louisiana, a very well-known children's hospital, Ochsner, in Louisiana, had 0 children in the hospital. They're now averaging 5 children a week in the hospital. Texas, 2.5 weeks ago, they had no pediatric intensive care beds. Florida, about 10 to 12 days ago, had 247 children in the hospital. And from my perspective, any child that's admitted to the hospital, and certainly any death, is preventable. And what we haven't talked about, and I wouldn't get off this conversation if I couldn't bring it up, which is, of course, I support vaccinations, but we can stop this in its tracks right today, right now, if I wear a mask and you wear a mask, if everyone wears masks in all instances, and particularly in schools and inside. There's just no other way to put it. At the point that Dr. Turner starts telling us statistics about children being hospitalized, we're behind. We're behind. So I hope the media, I hope you make this very clear in your report. Now is the time for parents and their children to wear masks.
Okay, our next question is going to come from Rachel Cohen.
Hi, this is Rachel Cohen from Boise State Public Radio. If this question has been addressed already, please let me know. But I was wondering about the call for volunteers by Idaho Health Systems. Do you know how many volunteers are needed statewide, where they're needed the most, and do people need certain training?
I love this question, Rachel, because we do want to get this word out. We need volunteers in healthcare settings across the state. I talked about this last week, where we have hundreds of open positions just in one healthcare facility alone, and we're hearing that resonate through the entire state. Some physicians need very specific medical training. That's why we're also putting a call out to physicians or healthcare workers that maybe have been, let their license lapse, they are retired. We are calling them back. We want to just kind of make this recruitment back into the workforce. We've been working with the boards of medicine, both the Board of Nursing, Board of Pharmacy, Board of Medicine, all those boards to help us make the process of getting those licenses reinstituted more easily, more readily. We are working with our local public health districts to help support our medical reserve corps. So if you go on to our volunteeridaho.com site and you want to sign up, you can say what your training, your skills may be, what your interest is. The health districts also go in regularly to pull down and reach out to people that have signed up to through the volunteeridaho.com site. So it's a wide variety of positions that are available, a wide variety of skill sets. We need positions in every reach of the state, any support that we can get. And sometimes even the health districts themselves are seeking support, and they're reaching into the Medical Reserve Corps to help with some of the, case investigation work, contact tracing, even down sometimes when they get overwhelmed, even data, something as simple as data entry that doesn't require, huge level of skill set. So please, we're really trying to get that word out to get people to volunteer their time.
Okay, our next question is going to come from Kevin Richard again.
Oh, I'm sorry, I had my hand up.
Oh, okay. It looks like Becky Boone this will be our final question of the day. So go for it, Becky.
Okay, and I think it's a quick one. I'm wondering about immunocompromised people who get that third dose, if that will be logged separately within the state dashboard, so we know if it's additional people getting vaccinated with first dose, or if it's just somebody getting their final dose in the series.
Thanks. I'm going to see if Sarah Leeds would like to answer this.
Sure. Thanks, Elke. Yes, we are working on the dashboard updates to indicate those third doses. I can tell you that as of the end of Monday, when we ran the numbers, we had 2,517 people who had gotten their third dose. We don't know that they were absolutely immunocompromised, but we do know that that's the way it was administered as a third dose, since the emergency use authorization was expanded for that. So
thank you.
All right, we're going to go ahead and wrap it up for today. We are planning another media briefing at 2:30 p.m. Mountain Time on Tuesday, August 31st. And thank you all for joining us today.